Hello, this is Registry Partners Oncology Coding Break for April 2025 on the topic of exploring the landscape of neoadjuvant therapy. Our agenda for this presentation includes a neoadjuvant therapy overview, grade post-therapy clinical and grade post-therapy pathological, lymphovascular invasion and how that is affected by neoadjuvant therapy, AJCC YC staging and YP staging, SEER data field neoadjuvant therapy along with neoadjuvant therapy clinical response and neoadjuvant therapy treatment effect. We'll also talk about some typical drug treatments per some sites and a case example at the end. Neoadjuvant therapy may encompass radiation therapy, chemotherapy, hormone therapy, and/or immunotherapy. It must be initial therapy. It is used to kill cancer cells within the primary or that have spread to other tissues or sites. Commonly used to treat breast, lung, pancreatic, esophageal, and rectal cancers, aiming to shrink or completely eliminate tumors. It may also be used to aid in the operability of otherwise inoperable tumors, such as assisting with safer surgical removal, reducing the risk to the patient. And it may be used to preserve as much as the organ or tissue as possible. For example, in breast cancer, the goal for neoadjuvant therapy is to shrink the tumor and preserve as much breast tissue as possible, avoiding a more extensive surgery such as a mastectomy. It may also be used to improve patients' long-term outcomes and reduce the risk of recurrence. A quick overview of the neoadjuvant process is the diagnosis first, along with workup to determine what type of treatment is available. The neoadjuvant therapy starts with the systemic or radiation therapy first, and then the adjuvant surgery. Next, we'll talk about grade post-therapy clinical YC. Grade is a measure of the aggressiveness of the tumor and is an important prognostic indicator for many cancers. So for post-therapy clinical, we have following neoadjuvant therapy, we assign the highest grade when the primary tumor is microscopically sampled, such as a primary site biopsy. We leave it blank when there is no neoadjuvant therapy performed, or we can assign code 9 in this data field when there's microscopic sample is done after neoadjuvant therapy, but the grade is not documented. Grade post-therapy path YP. Following tumor resection after neoadjuvant therapy, we assign the highest grade from the YC or the YP timeframe. The grade obtained prior to neoadjuvant therapy cannot be used, such as grade clinical. To apply YC grade in the YP grading field, each grade must use the same grading system. Otherwise, we cannot use the YC grade. We leave the post-therapy grade blank when there is no neoadjuvant therapy performed, when there is no biopsy performed following the neoadjuvant therapy and before surgery, or when neoadjuvant therapy is completed but no surgical resection. We assign code 9 when the neoadjuvant therapy is completed, followed by the surgical resection, and there is no grade documented on the post-therapy clinical pathology report and no YC grade. Also, assign code 9 when there is no residual cancer and no YC grade documented or no post-therapy biopsy performed. Next, we'll talk about lymphovascular invasion. We'll go through an exercise and then have more information on the next slide. For our case, we have an 815 exploratory procedure with biopsy LVI is unknown. The patient had chemotherapy on 9/1 and on February 1st in the next year, a robotic radical cystectomy with LVI positive. So for our case, we have lymphovascular invasion before neoadjuvant therapy as unknown and lymphovascular invasion after neoadjuvant therapy as present. How do we assign this for LVI? We assign this with code 1, present or identified. Lymphovascular invasion is a prognostic indicator. Documents the presence or absence of tumor cells in the lymphatic channels or blood vessels in the primary tumor microscopically noted by the pathologist. If LVI is not present before neoadjuvant therapy and present after neoadjuvant therapy, we assign code 1. If LVI is present before neoadjuvant therapy but not present after neoadjuvant therapy, we can assign 1. If LVI is present before neoadjuvant therapy but it's unknown after neoadjuvant therapy, it is a 1. And with our case example, if it's unknown prior to neoadjuvant therapy but present after, we assign code 1. Here is a recreation of an LVI table that's also in the story manual. And the running theme is that if LVI is present prior to neoadjuvant therapy or after neoadjuvant therapy, it is documented as code 1. Tumor size summary. For cases with neoadjuvant therapy, record the size of the largest tumor prior to neoadjuvant treatment. Do not document from the surgical pathology report. This is due to the tumor size hopefully being affected by the neoadjuvant therapy and it shrinks. If the size of the largest tumor before neoadjuvant therapy is unknown, and the size of the tumor after neoadjuvant therapy is known, the tumor size will be assigned 999. If the tumor size is larger after neoadjuvant therapy, record the clinical tumor size if known. Sometimes we might just know that it's larger but not know the size. If we don't know that, it is still 999. Also, behavior is always documented from information prior to the neoadjuvant therapy. Next, we'll talk about AJCC, YC, and YP staging. Here is our first exercise. We have a 10-12 EGD with biopsy, esophageal cancer, malignant neoplasm with GE junction measuring 38 centimeters to 34 centimeters. On the same day, the path report showed GE junction biopsy, invasive adenocarcinoma with signet ring cell features or ring features. On November 2nd, the CT PET thorax abdomen pelvis showed the esophageal mass, history of malignancy. There were a few paraesophageal and paratracheal lymph nodes, too small to characterize, and paratracheal lymph nodes which are commonly reactive, metastatic disease not excluded. On 11/8, the chemotherapy was administered, and on 12/19, the radiation was given. On April 6th of the next year, the esophagectomy was performed, EGJ, adenocarcinoma, grade 2, moderately differentiated, 1.5 centimeter tumor size, invades the muscularis propria, 0 out of 15 lymph nodes positive with unknown lymph node location, and after that, the patient started with the nivolumab. So how would AJCC YC staging be assigned here? And how would AJCC YP? YCT blank, YCN blank, and YCM blank staging blank, YPT2, YPN0, CM0 stage 1. We are picking YCTNM blank with stage group blank because we don't have the information available to us, while the YC staging can include clinical history and physical exam information, imaging, and diagnostic procedures such as the biopsy. The time frame needs to be after neoadjuvant therapy and before planned surgery. So we have the YPT2 because of the invasion to the muscularis propria. In this time frame, the YP criteria can include all post-therapy clinical info, as well as adjuvant treatment findings from the pathology report and surgical notes or operative report. Here is our next exercise. On August 31st, H&P states the patient was informed this was likely GYN cancer. September 1st, a CT abdomen pelvis was performed. Findings were suspicious for at least partial colonic obstruction at the level of the distant transverse colon, secondary to intrinsic narrowing from omental caking. Findings suspicious for primary ovarian neoplasm with metastatic disease to the peritoneum. On the path report for 9/1, an omentum core biopsy was performed with high-grade serous carcinoma. On September 11, the neoadjuvant therapy was started. And on November 27, there was a total abdominal hysterectomy with bilateral salpingo oophorectomy and omentectomy. The path report showed no gross residual disease. How would the AJCC Y staging be assigned? And what about the YP staging? YCT blank, YCN blank, CM blank with stage blank. And for the YP staging, it is YPT0, YPN0, CM0, stage blank. The AJCC YP staging is going to be this due to the complete response of the adjuvant surgical path after the neoadjuvant therapy given. Some might think it should be stage group 0 since T and M are all zeros, but typically stage group 0 is reserved for in situ in a non-invasive stage. Exercise 3 starts with an H&P. Patient presents with self-palpated lump in the right breast. On May 1st, the mammogram and ultrasound showed a highly suspicious mass in the right lower quadrant. It corresponds with an area of palpable concern and measures a 2.6 centimeters. The right breast biopsy was performed on 5/8. Invasive mammary carcinoma, ductal type, grade 2, ER 90% positive and PR 90% positive with HER2 positive. 5/31, the breast MRI was performed. Biopsy-proven malignancy appears to be only malignant lesion, measuring up to 3 centimeters. On 6/12, neoadjuvant therapy was performed with Taxotere, carboplatin, and Herceptin and pertuzumab. Later in October, the MRI breast was performed. Slight decrease in size of enhancing biopsy-proven invasive carcinoma right breast, currently measuring 21 millimeters, previously 30 millimeters. On 10/28, the right breast lumpectomy and sentinel lymph node biopsy showed invasive ductal carcinoma grade 2, 21 millimeters single focus with 0 out of 2 sentinel lymph nodes positive. And after that, the adjuvant immunotherapy and adjuvant radiation therapy were performed. So how would AJCC YC staging be assigned here? And how would AJCC YP staging be assigned? YCT2, YCN0, CM0, stage group 8-8. YC staging is assigned in 8-8 because there is no prognostic stage group table for breast post-therapy staging. YPT2, YPN0 with the SN suffix for sentinel lymph nodes. CM0, stage group 8-8. We see a decrease in size of 30 millimeters, YCT2, to 21 millimeters, but it remained a T2 for post-therapy path staging. YPT2, YPN0, and YPM0 stage 1A was dictated from a physician. However, we are not able to assign the stage group post-therapy pathological for breast. Additionally, for tumor size, we would record the largest tumor prior to the neoadjuvant treatment, which would be 30 millimeters. Continuing with exercise 3, I wanted to show what should be our SEER summary stage. So for neoadjuvant therapy cases, we assign the greatest extent of disease, whether it is from clinical or pathological findings. If clinical extent is greater than pathological, we assign based on the clinical. If pathological extent is greater than the clinical, we assign based on the pathological. And our SEER summary stage would be code 1 localized. This is our last exercise for AJCC, YC, and YP staging. This is the esophageal carcinoma imaging workup performed, and the esophagus biopsy was done with positive result of carcinoma. It showed a clinical stage of CT3, CN1, CM0, stage 3. Neoadjuvant treatment was administered with chemotherapy of cisplatin and 5-FU with radiation therapy. The post-neoadjuvant upper endoscopy and esophagus biopsy was performed, which showed 0.8 centimeters residual tumor invading the submucosa. The oncology note after the neoadjuvant therapy stated there was a small residual carcinoma, no regional lymph node mets. Patient had partial response to treatment and adjuvant surgery is no longer recommended. Plan for adjuvant systemic therapy. So based on this, what would our AJCC YC and YP staging be? We have YC T1B, YC N0, CM0 stage 1. The YC staging is only required when the planned surgery following neoadjuvant therapy has been canceled, such as this case. Then we have YPT blank, YPN blank, and CM blank stage blank. The clinical stage CT3 is invaded to the adventitus, and the YCT1B invades the submucosa, so it is smaller. So AJCC staging, YC, shows the level of neoadjuvant response compared to AJCC clinical staging prior to resection. We use YC staging when there is excellent response to neoadjuvant therapy and surgery is no longer recommended. The thing to remember here is that the surgery is no longer recommended we don't have to see the actual excellent response terms being used for AJCC. We use AJCC when there is no response to neoadjuvant therapy and surgery is no longer recommended. The lack of response from neoadjuvant therapy is not labeled progression unless the physician states it's progression. We use YP when there is a good response to neoadjuvant therapy and surgery was recommended and performed. The YP is applicable for the adjuvant surgery. Note that registrars can collect the YC staging in these scenarios, but are only required to collect YC therapy when surgery is no longer recommended. See SEER 2025. The YC stage and YP stage will always remain the previous M1 category. Registrars are required to collect 2 out of the 4 possible stage groups: clinical, clinical YC, pathological, and pathological YP, but we can collect more than 2. This was a compromise that AJCC and the standard setters came up with when AJCC wanted to introduce the YC staging. Next, here's an exercise for prostate. On 426, an outside path for prostate needle biopsy showed positive for adenocarcinoma, and 5.1, a physician note stated the patient will be placed on Lupron while deciding treatment options. On 8.6, the path for radical prostatectomy showed positive for acinar adenocarcinoma. So what is the date of first course of treatment? This is going to be 5.1 hormone therapy. However, for prostate, Lupron is not considered neoadjuvant therapy given prior to surgery, so it will affect other fields. Limited systemic therapy may be given prior to surgery and should not be coded as neoadjuvant therapy. There's only one exception is when it occurs in specific clinical trials. This is to study the biology of cancer or in other circumstances to impact the biology of a cancer, but is not a full course of neoadjuvant therapy with the intent to have a surgical resection and shrink the tumor. Experimental drugs or drugs not yet approved by the FDA are not considered neoadjuvant therapy, only if the trial is specifically looking at the agent efficiency with neoadjuvant therapy per the Cancer Answer Forum. Next, we have the 3 SEER data fields for neoadjuvant therapy. This captures a full course of neoadjuvant therapy, which is generally 4 to 6 months. It may also include a limited exposure of systemic therapy prior to adjuvant surgery. We assign code 1 for disease sites which neoadjuvant therapy is not standard of care, such as lymphoma, plasma cell disorders, and plasma cell myeloma. We assign code 1 when neoadjuvant therapy is completed and with or without planned surgical resection. Assign code 2 when neoadjuvant therapy was started, but a full course was not completed or neoadjuvant therapy failed. Assign code 3 when there was some type of tumor-directed therapy and it was not titled as neoadjuvant therapy prior to a surgery, such as our Lupron prostatectomy prostate case. This is also required for cases 1/1/2001 and forward. Next is our neoadjuvant therapy clinical response. This documents the outcome of neoadjuvant therapy stated by the managing physician, such as the medical oncologist, radiation oncologist, or surgical oncologist. The physician should base it on clinical history, physical exam, biopsies, imaging studies, and other diagnostic workup. The coding options can include complete clinical response or partial clinical response, progressive disease or stable disease, or no response. As a note, we cannot take information from the surgical path report for this data item. SEER neoadjuvant therapy treatment effect. This data item differs from the AJCC's post-therapy pathological response. We use the pathologist's statement from the surgical pathology report for this data item. We record treatment effect on the primary tumor or site, with or without lymph nodes and or distant metastasis. Codes 1 through 4 are referenced in the Appendix C for the site-specific modules. Code 9 is used when the patient starts treatment and the treatment effect is not available at the time of reporting. Here is the colorectal list example that we would get in Appendix C. This data item is only based on the surgical path. We actually assign code 9 when the only information available is the physician's notes. Here is a table I created for neoadjuvant therapy data field along with neoadjuvant therapy clinical response. On the left are the descriptions and on the right are the codes that match up. So if we had neoadjuvant treatment completed according to the treatment plan and the patient showed progressive disease, we would document 1 for neoadjuvant therapy and 3 for clinical response. If we had neoadjuvant therapy started but not completed or unknown if completed, along with a no response, our documentation would include neoadjuvant therapy as a code 2 and a code 4 for clinical response. Also as a note, per SEER, if the managing physician states excellent for a clinical response to neoadjuvant therapy, this is documented as code 8 for now. Let's walk through an exercise using both fields. On 6:15, we have a colonoscopy mid-rectum adenocarcinoma. On 7:1, there was a liver mass biopsy, carcinoma consistent with metastatic rectal adenocarcinoma. On 7:10, there was a note CT3, CN1, CM1A, stage 4A. The patient started FOLFIRINOX. December 10th, later on in the year, the patient had an LAR with residual invasive adenocarcinoma, 1 out of 12 lymph nodes positive. And on 12/30, the physician note stated YPT3, YPN1A, PM1A. Physician stated partial clinical response. So for neoadjuvant therapy data field, we will code 1 for completed. And for neoadjuvant therapy clinical response, we will code 2 partial clinical response. Here are some data items that are not affected by neoadjuvant therapy: perineal invasion, macroscopic evaluation of the mesorectum, regional lymph nodes positive and examined. So if those are done on adjuvant surgery after neoadjuvant therapy, we will document those as normal. And mets at diagnosis: assign involvement or absence with no regard to neoadjuvant therapy unless determined to be disease progression. Here are some common neoadjuvant systemic treatments for breast and rectal cancers. Herceptin and Perjeta. The Herceptin is given through an IV into a vein or by an injection every 3 weeks. It can be given with neoadjuvant chemo, but not at the same time as the adriamycin. And also Keytruda can be given for a neoadjuvant therapy for breast. Rectal cancers can be given chemotherapy with the capecitabine, 5-FU, Volfox, etc. For immunotherapy, it can be given the nivolumab and the pembrolizumab. The bolus 5-FU/leucovorin is an option for patients not able to tolerate the capecitabine or the infusional 5-FU. Here are some other common systemic treatments for neoadjuvant therapy. The esophagus with chemotherapy is cisplatin, 5-FU, carboplatin, and paclitaxel. For the immunotherapy, it's the nivolumab, the pembrolizumab, the tremelimumab, and the durvalumab. And for melanoma, it's a lot of the same immunotherapy agents. Here we have arrived at our case scenario. We'll go through the details of this case and we will use it for lots of different fields: date of diagnosis, primary site, histology, a lot of the neoadjuvant therapy fields as well, along with staging. So first we have 4.1, H&P stated that the patient presented with jaundice and flank pain. On 4.5, the CT abdomen pelvis showed a mass in the head of the pancreas consistent with neoplasm with intra and extrahepatic biliary dilatation with the pancreatic duct, no enlarged lymph nodes. The MRI of the abdomen showed a 30 mm mass in the head of the pancreas, likely pancreatic adenocarcinoma, extension to and probably involving the second portion of the duodenum. Pancreatic mass causes obstruction of the common bile duct. On 4.12, the diagnostic FNA of the pancreas mass showed an invasive, moderately to poorly differentiated adenocarcinoma. The bile duct brushing was also positive for adenocarcinoma. On 5.1, the patient started the neoadjuvant chemo with Volfox for 4 cycles. On 8.1, the MRCP showed a decreased size in the primary pancreatic neoplasm, measuring 2.6 centimeters. On 10.4, the medical oncology note stated there was partial clinical response and referred to surgical oncology for the planned surgery. The patient had the surgery on 11.1, pancreaticoduodenectomy, showed a pancreas ductal adenocarcinoma, 0 out of 14 lymph nodes positive, grade 2 moderately differentiated, 2.7 centimeters for the size, involved by direct tumor to the ampulla vater, duodenal wall. There was a treatment effect that was partial. There was extensive residual carcinoma and no evident tumor regression. The LVI was negative with invasive carcinoma at the margin. On 12.1, a radiation oncology note stated there was a course of postoperative chemo radiation recommended, and the patient does express desire to pursue that treatment. First, we have the primary site as the head of the pancreas, C25.0. Then we have the histology as 8500/3 for ductal adenocarcinoma. Grade clinical will be a 3 based on the poorly differentiated grade from the FNA of the pancreas. Grade post-therapy clinical, YC, is blank. This comes from the solid primary tumor, but it was not microscopically sampled following neoadjuvant therapy and before adjuvant surgery. Grade pathological is 9. Because neoadjuvant therapy was administered, we assign code 9 here. This data field cannot be blank. Grade post-therapy path YP is a 3. The adjuvant pathology showed a grade 2, however, we are taking it from the post-therapy clinical workup. The lymphovascular invasion is going to be a 9 because prior to neoadjuvant therapy it was unknown, and after neoadjuvant therapy it was not involved. And tumor size summary is 030 because we take the largest size prior to neoadjuvant therapy. Then we have our AJCC staging, our SEER summary staging, and our neoadjuvant therapy fields from SEER. Our AJCC clinical stage is going to be a CT2, CN0, CM0, stage group 1B, with a 30 millimeter tumor mass, no extension, invasion into the duodenum is ignored, no regional lymph nodes, and no Mets. Our AJCC post-therapy clinical, YP, will be a YCT2, YCN0, CM0, stage group 99. There was a decreased size to 26 millimeters, but it remains a T2, no regional lymph nodes, and CMO is carried over from the clinical stage, along with no stage group. Then we have a AJCC pathological stage. These are all going to be blank because there was neoadjuvant therapy. The AJCC post-therapy path, YP, will be a YPT2, YPN0, CM0, stage group 1B. The 2.7 centimeter size is our YPT2. All regional lymph nodes were examined and negative, along with the clinical negative metastatic disease carried over. So the CMO carries over. Our SEER summary stage is a code 2 based on the regional by direct extension to the duodenum invasion. And our neoadjuvant therapy field is a 1, completed according to the treatment plan and guidelines. The neoadjuvant therapy clinical response is a code 2. The physician note stated there was partial clinical response. And the neoadjuvant therapy treatment effect will be a code 3. Partial response noted from the pathology report. Here are some quick tips. For grade post-therapy path, YP, we can use the grade post-therapy clinical, YC, but never anything prior to neoadjuvant therapy. We assign lymphovascular invasion code 1 if LVI is identified at any point in a neoadjuvant case. The tumor size summary can only be documented prior to neoadjuvant therapy. The AJCC YC stage can be assigned for cases diagnosed 2021 and forward, but is required only for cases where surgery was planned but not carried out. AJCC YPT suffix and N suffix can be used when applicable. And neoadjuvant therapy does not affect the data field of macroscopic evaluation of the mesorectum. And SEER neoadjuvant therapy and SEER neoadjuvant therapy clinical response fields relate to each other, while the SEER neoadjuvant therapy treatment effect is only assigned from the pathology report and is site-specific SEER Appendix C notes section. Thank you for joining me with this presentation on neoadjuvant therapy.